All right, this article that came out in 2025 is really awesome. It hits a lot of points that I teach when I'm talking about myelopathy to people. Really good research group, and it came out in Journal of Manual and Manipulative Therapy. So we're going to hit the highlights, things that I had highlighted throughout here. Otherwise, you could spend a long time on this, which isn't a bad thing. But if you don't have a long time to spend on it, this video should make it a little bit quicker for you. It's been estimated that 75% of patients with degenerative cervical myelopathy report non-consistent episodic changes in symptoms with asymptomatic periods lasting months to years. So basically this will fluctuate. And so you need to remember that. Early on here we're going over what are people going to present like to you. They'll fluctuate, and oftentimes it can be for a while. And people with degenerative cervical myelopathy frequently experience misdiagnosis or substantial diagnostic delays for at least a couple of years. It's because of those inconsistent, fluctuating symptoms that can masquerade as other things. There's a nice video here of all the things that can impinge on the spinal cord and the cervical spine related to degenerative cervical myelopathy, which is different than an acute injury that in somebody younger that isn't showing degenerative processes. With this, physiotherapists or physical therapists may be the first to recognize the condition, and we'll see why as we look here at table 1. A lot of these, I'm going to zoom in here, a lot of these symptoms are things that would be referred to us. Some of those you'll see as pain, some of them are weakness, some of them coordination, a gait impairment. People come into us for balance, and a lot of those are early to middle stages, and if we can catch it quicker, we might be able to get on the appropriate pathway more quickly. Don't just assume because they're old that these things are happening. Now, sometimes deconditioning may be a part of it, but we need to look at some of the clinical testing that's here to make sure that we are not assuming that we just need to train them when there's actually a neurological upper motor neuron sign occurring. With reflexes, particular attention to hypertonicity. So really what I see is when it like whips back at you. So it's not just, oh, it's a little bit higher, but it whips back. Now we need to remember that if there's lower motor on upper motor, so there's lower motor neuron signs with upper motor neuron signs, lower motor neuron do win. And as people age, their reflexes do decrease a little bit. So we need to take that as a part of the picture, and there's no one finding that is universal here. Partly because we find different degrees of myelopathy, people respond differently to it, we don't know why, and it's also at different levels, and they may have other areas of pathology where there might be a radiculopathy as well as a myelopathy up in the cervical spine, or central canal stenosis or foraminal stenosis down in the lumbar spine that can affect all of this. We're going to look at Hoffman's and Tromner signs specifically. Babinski, I don't use Romberg's as often. You can. I find these to be a little bit quicker than I do. And then hyperreflexia, so tendon reflexes, and inverted supinator sign. Tromner's sign is a reverse Hoffman's. So we flick the finger, we just flick it up instead of down. Babinski, notice that one, it says it demonstrates higher specificity for degenerative cervical myelopathy with a poor modified JOA score, which is Japanese Orthopedic Assessment Score. And so basically, if they're worse, Babinski's more specific. So if we find Babinski, more likely that it's already progressed quite a bit. Deep tendon hyperreflexia, we talked about that a little bit already. It's better in the lower extremities than the upper extremities. My belief is that there's also radiculopathy in the upper extremities, so that you don't notice it quite as much. Where in the lower extremities, you get the full force of the upper motor neuron sign there. Unless, of course, they also have lower motor neuron findings in the lumbar spine, like central canals or foraminal stenosis. Early motor dysfunction may manifest as progressive weakness of the intrinsic muscles of the hands due to anterior horn cell damage. So a lot of times people notice they just feel like they're getting weaker. They figure they're just getting older, but that can go along with the clumsiness. It's weaker. I can't button my shirt as well. I'll often ask about buttoning or cutting food. Things that require fine motor control. We want to look at strength and see where they fit. Now, can somebody just have lower grip strength? They could. So we have to look at everything together. Oftentimes, if you're going to be looking at strength, which is a great thing to do as a physical therapist, it's going to be non-myotomal. And so we need to look now, is that just them getting weaker? Again, we take it as all part of the package. Gait, what we're looking for is reduced cadence, so they're walking slower, and their gait is a little bit wider. They have their feet wider than what we think would be normal. We may not have known them when they were normal, but it should be wider than what you would consider normal, and decreased step length. And so they're not going out as far. With that, since they like a wider gait, they don't like tandem walking, which can be maybe more difficult. Now you can say, well, they're getting older, just more difficult balance. We have to take it as part of the package, and if we're not sure, we don't want to just be treating somebody like they're getting older when there may be upper motor neuron pathology. Lermite sign, that's often not present. Sometimes it is, 27% of cases. But if it is, that definitely means something. So if you have them look down, you're a little overpressure, and they're feeling, a lot of like those electrical feelings, we need to take that into account. The modified JOA scale, it's later here in this paper. Find it online. It asks a few easy questions, pretty easy to grade. We want to be able to look at that. I find that's easy to submit with my clinical findings when I need to get imaging, which leads us to the next one, imaging. So if I've done the modified JOA, I have some of their symptoms. Really, I like some hard clinical findings. If you write Hoffman's or Tromner's, Babinski, ankle clonus, that's something that other healthcare providers recognize, like, okay, yeah, we need to look at this. And MRI is really good. X-rays don't show much. Sometimes it's recommended to still do X-rays first because X-rays are almost always recommended before MRI, but that's not a must with cervical myelopathy because it typically doesn't show anything. If it does show degenerative findings, we want to get an MRI. If it doesn't, we still want to get an MRI because we haven't been able to see the cord. Typically at that age, we're going to find something on X-ray, right? But we find a lot of those findings in X-ray with people without myelopathy. So no matter what, we need to get that MRI if that's what we're considering. CT may be helpful, especially if they can't have an MRI, and sometimes surgeons are going to want that as well. A quick note on radiography is we may need flexion extension. That can be helpful for instability. I've found that as well with people that they've already had that ordered, and it can increase suspicion. That's why maybe they're also inconsistent. Again, early stages masquerades as other things. This is a great way to stage it here in figure 2. We're more often going to see that lighter row at the top. With the chronic, it's been going around for a while. See, the first thing that they may be complaining of is neck pain and stiffness, something we're really good at. And then those we need to watch, and it may be appropriate, treat them a little bit. What if 2 or 3 sessions we get them all better? It probably wasn't myelopathy. But if we're on the fence, they're not getting better after a few sessions, they're maybe even getting worse, they're just not making progress, or they're making a little progress and then you keep going and they don't make more, that's when we want to look at this. If it's newer, more rapidly starting, depending on how quickly that is, would put it in which of these red ones that we're looking at here. Then that determines how quickly we get an MRI. So we need to make sure that we talk to patients about what we're considering. Sometimes we want to make sure we're positive and we don't put any fear in patients, but they need to know if we're recommending they get imaging, this is what we're looking at, so they're not shocked. We also need to say that people can do really well with this, and it could solve a number of their problems. But if they don't do it, it could be progressive. It depends on how quickly it's been progressing so far. If it hasn't progressed much over 5 years, it's probably not urgent, and they may be able to be fine just waiting. Some people would rather do a wait and see approach, which is fine. If it's not progressing, that's totally fine, but that should be their decision, not our decision. We also don't want to, if they're rapidly worsening, not talk to them about what are the consequences of waiting. That's not shared decision making. That's just leaving it up to them and not doing a good job communicating what you know as a doctor. Again, surgeons are going to be looking at, they're going to be the one doing the surgery. If they find a reason not to do it or whatnot, again, the shared decision making should be led by them, but it started with us. And if the surgeon doesn't do a good job with the shared decision making, then we can help lead them to it. Maybe they need to consult a different surgeon if they're getting worse and the surgeon didn't want to do it for some reason. But that is sticky area that we need to make sure that we are helping that person get the best care they can and talking to the surgeon, telling them what we're seeing. In my experience, it's done very well, but it does depend on the relationship with the surgeon. The rest of it talks about management. It just depends on what you think the prognosis is. But if they need a surgery, we need to be getting them to the surgeon. So that's where I ended the focus of this review there.